Hello everyone, my name is Jack Schneider, and I'm so honored to be part of the annual Pediatric Review Conference this year. I must say, I am a bit bummed that I can't be there in person, but of course, I hope in the near future that I'll be able to join all of you, at least in Jordan, as I've heard so many great things about the experience from my colleagues here. So really looking forward to that one day. Just to give you a little bit of background, I am an adult and pediatric infectious diseases doc, and I was trained here at IU in both internal medicine and pediatrics, and then did a combined fellowship in both adult and pediatric infectious diseases. So I split my clinical time between both departments. And I also direct the Antimicrobial Stewardship program here at Riley Hospital. And so, of course, when the request for an antimicrobial stewardship talk came through, of course, I jumped on that just with my leadership position here, but also that I wanted to bring up a new topic today that centers around antimicrobial stewardship, and that's diagnostic stewardship and how we implement rapid diagnostics into our workflows to really enhance our stewardship practices. So really looking forward to going over that with you today. And with that, I have no disclosures or conflicts of interest in this presentation. And some of the objectives, I am, as I said, going to talk about rapid diagnostics. So these syndromic molecular testing panels, I'm going to highlight some characteristics and also illustrate how some of these panels can improve patient care. And this is compared to our conventional cultures. And then I also want all of you by the end to really be able to identify opportunities for expanding diagnostic stewardship efforts within all of your own stewardship programs and just stewardship practices. So I want to talk briefly about antimicrobial stewardship programs. And overall, I know many of you are aware that effective stewardship programs have really led to improved clinical outcomes and really a decrease in overall adverse events, especially when these antimicrobials are optimized. And that's why I think it's so reassuring just to at least review my second point there, is that these stewardship programs are widely adopted and they are regarded as safe just because we haven't seen an increase in patient mortality despite reduced antimicrobial use. In fact, Joint Commission, who is in charge of our accreditation process in the US, now requires stewardship programs in order to be accredited. And to be honest, each year there's even more and more requirements. So it seems like they really do push us to grow our stewardship program. And as a result of their recommendations, we have really started to have more of an outpatient presence. And that started with our outpatient parenteral antimicrobial therapy program that we just started last fall. So I only anticipate that there will be even more requirements to come. Yes, there's always room for growth, and really looking forward to at least coming up with new initiatives. So as I promised you at the beginning, we would talk about rapid diagnostics. And so for this first part of the presentation, I will do a little bit of review of these syndromic panels. But I really want to focus in on how rapid diagnostics can impact antimicrobial stewardship, just because they can, I know I put here, transform the management of infectious diseases, but they really can, just because with all these new diagnostics that are available, we can get diagnoses so quickly. And how are we going to act on those? There's just so much opportunity there from a stewardship standpoint. And of course, we'll get into the diagnostic stewardship potential as well. But you can just see that there's just so much talk and so much excitement around rapid diagnostics because of its potential. But the one thing is that you need that multidisciplinary approach to really develop these effective interventions so that you can maximize that benefit of these diagnostics. Because as we'll get into, of course, these diagnostics don't come at a very cheap price, and so you want to use them effectively. So that leads into this official next section of just how I'm going to show you just with rapid diagnostics, when used effectively, can enhance overall stewardship practices. So Dr. Messaker is a pediatric infectious disease doc out of Colorado, and I think he does a lot of antimicrobial stewardship, diagnostic stewardship, PCR-based panel studies. And I think he did such a wonderful job in his paper in 2017 of really outlining key considerations for antimicrobial stewardship implementation of these rapid disease diagnostics. And really it comes down to the key questions. Will a clinician understand the test result? So of course we can, our reporting language, perspective audit and feedback, how we provide that education to providers, Such an important question to consider. The next is, will the clinician appropriately modify antimicrobials based on the test result? So using practice guidelines, using your electronic health record to really help guide physicians based on the result, and also that prospective audit and feedback that I talked about just with our last question. And of course, will the clinician act upon the test result promptly? That's the biggest thing, is that are we getting that just at the right time? And is it in the electronic health record, so that when that result is available, the clinician is acting on it in a timely manner, so that it really does have a true effect for the patient. So there's a lot of advantages of rapid diagnostics. And so, of course, faster identification of pathogens, and also these resistance gene markers that we have on most of our blood culture panels. Also decreased time to appropriate escalation and de-escalation of antibiotic therapies. So of course, we don't want somebody on inappropriate therapy for that long. So with some of these rapid diagnostics, if they detect something that we aren't covering with our empiric treatment, it's always wonderful to know that we can change that therapy much faster than what we were doing before with just conventional methods. And of course, it provides an improvement in sensitivity compared to conventional methods. So of course, if it's there, it will likely detect it. Now, that can cause problems, which we'll get into in a little bit, but I think overall increased sensitivity is always good for a rapid diagnostic. Now, even though there are advantages of rapid diagnostics, we do need to consider the challenges as well. And especially with our molecular diagnostic platforms, we cannot always distinguish true infection from false positive tests. This can be very challenging, especially for respiratory samples, where we get cultures back and it's hard to determine whether everything that we're seeing there is an indicative of an invasive pathogen, or is it just airway colonization. So that's the constant challenge that we have in many cases, and that's why SID docs get involved in these particular cases. I also wanted to mention genotypic markers of resistance. These are on generally all blood culture or rapid blood culture diagnostics. And these results can be really ambiguous, because even though they're present, they are not always expressed phenotypically. And this is especially true in gram-negative pathogens. Gram-negative pathogens like Acinetobacter and Pseudomonas, they may harbor other resistance mechanisms like efflux pumps and porin mutations. So that's why it's important that physicians understand that even though a resistance marker may not be there, that doesn't mean that there's some other, at least, mechanism at play, or resistance mechanism at play, that we really can't detect. So definitely something to consider. And also de-escalation based on possible susceptibility must be done carefully, because we need to take the whole patient case into consideration. So there are some patients that require more broad therapy, and if you de-escalate very quickly just based on one rapid diagnostic, that could have detrimental effects to a patient. So that can be a challenge as you try to educate patients on these rapid diagnostic panels. Challenges. Now the big thing is also cost management, and this is what labs who are always operating under a limited budget, they run into, is that these rapid diagnostics are very expensive. And so you have to consider that, and you also have to consider, as hospital-wide, if you are using rapid diagnostics and if all of a sudden it has increased sensitivity and you're picking up more organisms, are you going to increase antimicrobial use inappropriately? For example, like C. diff infections, if you're looking for certain PCR-based tests for C. diff, without doing more of like an algorithm or algorithmic approach, sometimes you can overcall C. diff infections. And so that can lead to an increase in antimicrobial use, which is always a concern. So that's why diagnostic stewardship, which we'll talk about in a little bit, is crucial. So that gets us to multiplex PCR syndromic panels. And right now, a lot of you are probably aware of current panels out there, like respiratory, GI, CNS, blood. Really the panel that everybody knows about is BioFire, just because a lot of labs have incorporated that into their just routine, just laboratory procedures, and a lot of stewardship programs have incorporated these into their diagnostic algorithms. But the big question is, are there proven methods in enhancing antimicrobial stewardship with these syndromic panels? And really, they're very successful when they're used in diagnostic algorithms, for educational efforts, when you co-test with other biomarkers, and also that targeted provider feedback. And To be honest, there was a great study from Timbrook back in 2016 that looked at a lot of these PCR-based panels and just rapid diagnostics. And really, most studies demonstrate there's not much of a benefit to them unless you have that effective antimicrobial stewardship protocol that's in place. And that's why I think with that second point, proven methods, it's really when they're effectively incorporated into stewardship practices, that's where you really see the most effect. Now, after hearing all that, just a quick summary on rapid diagnostics. We know that they continue to change quickly. Gosh, even around COVID, it just seems like each month we had something different. And even pre-COVID, we also had it seemed like one platform after another that was coming out. So there's always something new, which of course makes it interesting and fun. But that means that there needs to be more evaluation. So confirm the agreement with our conventional methods that we're using in the lab right now. Do they actually change clinical management? So a lot of these companies will let you bring an instrument in just to really test them on your patient population, just to see if it's really theoretically causing an effect or could cause an improvement, at least for your patient. And are they cost effective? As I keep saying, they're expensive. There's usually a lot of upfront costs. And can you really justify those upfront costs in the long run by, improving patient care, decreasing length of stay, removing something else within the lab, or at least a diagnostic procedure that you were using before, and this new diagnostic could take the place of? There's so many things to consider. But overall, when effectively used with stewardship, they really can improve clinical care. So that gets into this term that I keep bringing up about diagnostic stewardship and this symbiotic relationship with with antimicrobial stewardship. So what is diagnostic stewardship? So Jennifer Ross out of Infectious Disease Special Edition, she's a pharmacist. She did such a great job of summarizing diagnostic stewardship. Dr. Madden, just with his paper in 2018, also did a great summary. But really, diagnostic stewardship is a coordinated effort of ensuring appropriate tests at the right time for each patient, really to optimize antimicrobial therapy. And this is using evidence-based utilization of diagnostic tests, really to improve patient care, but also reducing costs, because of course with some of these tests, people just send everything, and that's not really the best way to diagnose a patient. So having safeguards in place can really enhance clinical care and also just reduce cost. And also falsely inflated hospital-acquired infection rates like C. diff because you may be over-testing things. So diagnostic stewardship can play a role in that, which is huge for infection prevention teams. One thing is, landscape is, overall for this is untouched. So it really does leave room for innovative approaches and evaluations. I'm even considering starting our own diagnostic stewardship team here at Riley. So there's so many opportunities ahead for this. And this goes back to Dr. Messaker, who had a great chart before that we referenced on antimicrobial stewardship considerations. Well, here he's doing diagnostic stewardship considerations. I won't go in all the detail, but some of his key questions are: is the test appropriate for the clinical setting? Will the clinical care of the patient be affected by the test result? And will the result be available in time to optimally affect care? These are the very important questions that we should all be asking ourselves whenever we send an infectious disease test or some type of diagnostic, just because some of these are very high priced. And is it really going to benefit clinical care? That's the question we should all be asking ourselves. And that's what our, at least job is as an antimicrobial stewardship team, and even maybe eventually a diagnostic stewardship team, is to help educate and guide clinicians to make those right decisions. So it's usually divided up into 3 different stages on target interventions. So there's pre-analytic, analytic, and post-analytic. I'll go into all these details a little bit further in the subsequent slides. So pre-analytical targeted intervention is when you focus on what the test is, or when the test is being ordered and collected. So these can be user-based approaches. So as they're auditing, price display, I know all of us, if we have something right in front of us that shows us the price, we always reconsider what we're ordering. Provider feedback, sometimes, in the outpatient setting, we'll provide provider feedback with antibiotics that they're prescribing. So if you do that for diagnostics, is that one strategy? What's probably most effective and what we have more experience with at Riley is system-based approaches. So modifications for the just the electronic medical record and how we do our diagnostic algorithms, also requiring negative culture and PCR data before next-gen sequencing is ordered, and even pre-authorization by ID physician or diagnostic stewardship teams. The future of diagnostics, I think, is really next-gen sequencing. So those are high-priced tests, and sometimes they have nuanced results that really need an ID physician to at least tease through a lot of these other results that may more or less muddy the overall picture. So I think having these stewardship teams in place to really help physicians understand these more advanced tests, I think, is always helpful. So this is really the pre-analytical phase, and again, that is being ordered and so the next phase is the analytical, and that is relating to laboratory practices, including those protocolized or reflex test algorithms. When we talk about BioFire, GeneMark, and our Luminex, which is a nanoparticle technology, these do yield organism ID very quickly compared to conventional culture. And with stewardship programs, they've been shown to decrease time to effective therapy and length of stay. And this next slide really highlights what we use here at Riley and is a true example of the analytic phase, in that we have incorporated an effective algorithm here so that if there is a positive test on our Verigene, we have an initial recommendation of certain antibiotics based on our current and local antibiogram data. It also has notes in there too for some of those nuanced cases or special cases, and that's really the point, or the point really for that is to capture those cases that may cause problems for some physicians that may not follow this set protocol. So all this is helpful, at least when physicians are ordering tests and deciding on which, if there's any further tests to do and which antibiotics to use. Now for post-analytical, there's implementation challenges. This is par for the course in laboratories providing these rapid diagnostics. Some laboratory workflows, they don't have 24/7 staff, so they're just incapable of doing it. So if you do a rapid diagnostic at 6 p.m., the physician may not get it until the next day at 8 a.m. Well, is that really beneficial to the patient, especially for the cost of the rapid diagnostic? Not always entirely the truth. So also it comes down to the EMR, or the electronic medical record capabilities, and also just the willingness and awareness of the physicians to respond quickly. So I think that just comes with education. So as an example of a post-analytical stage platform, I wanted to talk about the Accelerate Pheno system, which has caused a lot of excitement the last few years. And it's because it uses morphokinetic cellular analysis to provide susceptibility results, specifically the MICs. And you get an ID in 1.5 hours, that's your quick fish, and then or just fish technology, and then those MIC results within 6 to 7 hours. What's interesting is that these are rapid and actionable MIC results, and it can direct therapy very quickly. But we just need more studies to ensure this type of technology improves patient outcomes and justifies the higher cost, because it is quite expensive. But just as an example, because I just think it's really neat to show, is that with this morphokinetic analysis, you have two different E. coli isolates exposed to the same concentration of pip-tazo. So you can see the morphokinetic cellular analysis enables calculation of this range of MICs from a single antibiotic concentration. So you see a very low concentration. There's a susceptibility of 8, or the MIC. And now compare that to an MIC of 128, which is resistant. You can see the clone intensity graphs here with the growth curves over time that are affected as well. But I think this illustrates just how far we've come with rapid diagnostics and providing as as fast as a result as we can, even when it comes to MICs. But the problem is that this test is very expensive. So can this be incorporated into lab flows? So it's that post-analytical, stage that every stewardship team, every lab needs to evaluate to see if it's truly effective in their own institution. And that leads into the implementation challenges and safety concerns, because when a test is underutilized, does it raise the possibility for serious infections going undiagnosed? So if we're pulling tests away, are we missing diagnoses? So that's why we really need to consider and identify that sweet spot of test utilization, that we can minimize the overdiagnosis of false positive results, but maximize those appropriately indicated testing and true positive results. But of course, that'll be infection and population specific. And which outcomes should be tracked? I think every diagnostic that you incorporate, especially at least certain restrictions, you've got to look at length of stay, resistance rates, antimicrobial use, mortality, and readmission. So in developing effective diagnostic stewardship approaches, no one size fits all. It really comes down to institutional factors. So laboratory, stewardship activity, what kind of support do you have from hospital? What's your hospital-acquired infection rates, EMR capabilities, and barriers such as provider pushback, because maybe physicians need more education if they aren't aware of new technologies out there. Big thing is make sure you're flexible. Because even us as a stewardship team, I constantly encourage our group to be flexible, always reevaluate constantly. So all these new initiatives that we come up with, are we evaluating them? Are we looking if there's patient harm that's detected, or is it, our strategy? Is it, is it achieving its intended goal, or is it failing? And if it is, then perhaps we step back or make modifications. Just because every institution is different, but whenever a problem is identified, you always come up with creative strategies. But again, it's just so important to keep reevaluating to make sure that it's working effectively. So overall conclusions, rapid diagnostics, and I know I've reiterated this over and over again during this presentation, they really do have the potential to positively impact antimicrobial stewardship practices and inpatient outcomes, but you do need to weigh those risks and benefits to determine if it's clinically impactful and feasible, specifically for each of your institutions. And also make sure that the results are correctly interpreted and rapidly communicated, because of course you're going to direct clinicians to appropriate adjustment of antimicrobial therapy, but you have to do it in a manner that they receive well and that they're likely to act on. So that comes with a lot of perspective audit and feedback and education. And that's really key for any stewardship or diagnostic stewardship program, is to provide that education for all physicians so that they understand basically the testing process more, or at least better. Also, I know I've gone over this too, combined diagnostic and antimicrobial stewardship model, we know has potential to promote better patient evaluations, test choices, and decisions to prescribe antimicrobial therapy. And regarding diagnostic stewardship, which I know we covered a lot of today, it really should be multidisciplinary collaborative approach. It's similar to our antimicrobial stewardship programs, but I think it's wonderful because it does have an opportunity for collaboration, again, between clinicians, ID physicians, pharmacists, microbiologists, hospital administration, so many people. And I think when you have all of these great minds working together, overall patient care is improved. So just really exciting time for diagnostics, for antimicrobial stewardship and diagnostic stewardship. And as I said before, with diagnostic stewardship, the landscape is clear. So there are multiple innovative ways and innovative approaches and strategies that people are coming up with. So I'm excited to see, at least what's in store for the next few years as we see some of these new strategies people are utilizing published. So here at the end, I do want to recognize my antimicrobial stewardship team here at Riley, including my co-lead, Dr. Cousin, who is our ID pharmacist at Riley. Also, Dr. Samina Bumbra, who is our Associate Medical Director for Infection Prevention, John Christensen, who is giving a talk about vaccinations for the group. He is our clinical advisor. We also have a biostatistician. So I think all of these members have just been instrumental in making our program so strong. And again, hats off to our leadership that have provided us with this support. So with that, I do want to thank everyone for allowing me to come and talk about a topic that I'm truly passionate about. Like I said, I'm so eager, and I'm looking forward to the opportunity to come and present in person, and hopefully that'll be soon as next year. So of course, if there are any questions, feel free to reach out to me. I'm sure that my contact information will be listed. Always happy to answer questions. And go over, opportunities to collaborate or to exchange ideas. So wishing you all the best, and thanks again.